Morning, everybody. It's great to see you all up and joining us this morning. And so I want to shift our gears a bit today. This is going to be somewhat of a unique session compared to the rest of the course. But today we're going to talk a bit about the toxicities and just symptom management in head and neck cancer. And the reason we wanted to do this talk is really lay the framework for contouring, because everything that you contour and everything that you don't contour has consequences for the care that we give our patients. And so this is something that this is personally my area of interest, is really symptom management and symptom anticipation and mitigation. And so we wanted to spend a bit of time talking about this. As usual, we welcome your feedback. So as questions come up or thoughts come up, please feel free to put them in chat, and we'd love to talk about this toward the end. So as I think of our patients, really...
Sorry to stop you. I'm so sorry.
Yeah.
Sorry, Parag. Go ahead,
Yeah,
please.
no problem. So as we think of our patients and as you contour your cases, I think, the framework that I always think that helps, especially for young trainees, is to really think about anticipating what the side effects are going to be as you're contouring and planning your cases. And as you anticipate them, historically, as we've managed side effects, it's usually been once the side effects, have begun, we start treating them. I think over the last 5 to 10 years, there's been a lot of focus at really anticipating side effects and perhaps starting to do either prehabilitation or use strategies to mitigate them, to really decrease the severity of these side effects as they happen, or sometimes even prevent them before they happen. I certainly think that symptom management still remains a big part of what we do as we take care of our patients both during treatment and as they go into survivorship post-treatment. We're going to talk about each of the normal organs or the organs at risk that we think about in head and neck cancer. And certainly, I think we all realize that, treating head and neck cancer patients is a very unique population, because you really have, affect all of the main senses. We can affect their ability to talk, ability to chew, ability to swallow, ability to smell. And in locally advanced sinonasal cancers, even you're worried about their ability to see. And so we're going to start talking about the oral mucosa. As you can imagine, our oral mucosa has multiple different functions. I've listed them here. But really, as you talk about the oral mucosa, starting from the mouth and the oral cavity, going down into the oropharynx, all of these structures are exquisitely sensitive to radiation dose. And something that we'll talk more and more about is how to spare these organs, particularly as you plan with IMRT for these patients. Beyond the oral cavity mucosa and oral mucosa, the other organs that we really think about are really salivary glands, and really the cornerstone of using intensity modulated radiotherapy really came in decreasing the severity of xerostomia and sparing salivary glands. Saliva is multifunctional, certainly an important part of gustatory aspect of eating and masticatory aspect of eating. But saliva also has a significant digestive component as well as an antiseptic component, as you can imagine. So decrease in salivary function can affect beyond just taste and chewing. It can certainly impact our digestion, and really more important, just changing the microenvironment in the oral cavity in salivary pH can really affect your dental health, which I think that we all deal with our long-term survivors of head and neck cancer. Is really, that's probably the most common, message I get from patients 5-10 years down the line, is just the impact on dental health for these patients. And that remains a big issue. I just put in some of the side effects that we see both in short and long term for our patients, and you can see that it's overwhelming in head and neck cancer. Certainly, while these patients are undergoing treatment, you're primarily managing things like xerostomia, mucositis, nutrition, and pain. Those are kind of the most important side effects that we're dealing with, but you can see that there are significant long-term side effects that can be impacted in patients. Certainly long-term xerostomia, long-term dysphagia, in patients particularly with oral cavity tumors that undergo, significant large surgeries with flap reconstructions. Long-term dysphagia, aspiration remain a significant cause of long-term morbidity and sometimes even mortality in these patients. Chronic aspiration is a really serious issue. And, there are patients who, really succumb to and aspiration pneumonia long-term because of just chronic dysfunction and swallowing. I think some of the side effects that we underappreciate in head and neck cancer, even here in the US and elsewhere, is just the impact of radiation on cervical fibrosis and just cervical dystonia. It's something that we're becoming more and more aware of, particularly again in post-operative patients where, patients have had a neck dissection and then you're adding post-operative radiotherapy in these patients. Lymphedema is something we think about in breast cancer patients, but certainly an issue again in oral cavity and just head and neck cancer patients, particularly again in the postoperative setting. So if you've had a therapeutic lymph node dissection, very similar to breast cancer, right? If you're taking out a lot of lymph nodes, and these days it's not uncommon to look at a neck dissection and see that, we've dissected 50 to 100 lymph nodes. You're adding postoperative radiation to a heavily dissected neck. Certainly you can see lymphedema, and particularly we'll talk about level 1 lymph nodes soon. That's where you see lymphedema. When you're irradiating level 1 lymph nodes, you will see submental edema, or what I often will call the turkey waddle, that you'll see. You'll get neck, just submental edema, which can be very, very cosmetically and functionally devastating for patients. Dental health, we've already talked about, probably one of the most significant causes of late morbidity. And then other things that we think about really is just osteoradionecrosis. Again, something that you see particularly in postoperative cases, where this is in oral cavity cases, where significant portions of the oral cavity are in a radiation field, where really it's very difficult to spare any part of the mandible. And this is something that will put patients at risk. The last couple of late side effects are thankfully rare, but really, really serious. So just, carotid artery injury, where patients develop either a pseudoaneurysm or an aneurysm, and in worst cases, blowout. Again, not a very common side effect in the upfront de novo setting of radiation, but something is definitely a significant side effect to think about in re-radiation. And I think more and more, no matter what part of the world you're in, as our head and neck cancer patients are surviving and thriving longer and longer, and even in the metastatic setting, this is something that we as radiation oncologists are often called upon, is to treat patients with re-radiation, either for focal recurrences or in many cases now for a second head and neck cancer that shows up 5, 10, 15 years down the line in our patients after prior radiation. I just put in these most recent version of the NCCN guidelines, just showing the importance of multidisciplinary care. And I think really a lot of focus and thought has gone into just setting up multidisciplinary teams beyond physicians in the management of head and neck cancer. And I will say that here at UCSD, this is probably our biggest accomplishment of the last decade, is really putting together a robust multidisciplinary team that is engaged in taking care of our patients and managing of our patients, starting at diagnosis. And you can see that the range of services that come into play for these patients. Here, really things that I think about at UCSD, things like nutrition, speech language pathology, and ensuring swallowing. To me, those are probably my most important partners, but both at diagnosis and during treatment. And then really, thinking about head and neck survivorship. So in many places now, there's a lot of thought going into starting these survivorship clinics, where patients are really managed long-term with somebody who, with a focus in survivorship. And the nice thing about a head and neck survivorship person, this can be a nurse navigator. It doesn't require an MD. It just requires somebody who's trained in kind of managing head and neck cancer patients. Other important referral, I'm sure many of you do this in your practice, is really refer a head and neck patient to a dentist prior to any onset of therapy and certainly after therapy. But dental health really goes hand in hand with really management of head and neck cancer. In the US, this is a challenge. I think this is probably one of the things that we don't do very well here in this country. And it's really because dental care is not covered in the US by medical insurance. And I would say that the data suggests about 50% of head and neck cancer patients diagnosed in the US don't have dental insurance or a regular dentist as part of their care team. So this is a significant issue. Other partners in head and neck cancer are really our physical therapy and occupational therapy colleagues, who can be very, very instrumental in helping with symptoms of things like trismus, cervical dystonia, and certainly lymphedema. And then lastly, I will say palliative care, for places that have this model where there are a team of doctors and nurses and social workers that specialize in symptom management. I can't think of any other disease site in cancer that requires, a significant amount of symptom management. So if you can partner with somebody in a palliative care team and engage them in the care of your patients, I think that this is really, really worthwhile. And oftentimes, I think this responsibility falls on a family physician, a primary care physician, if you don't have routine palliative care available. So we'll start with the first poll. Hopefully we can.
Can you speak in English?
Oh yeah, of course. Sorry, Parag. Parag, I'm going to start the poll, but then before it, I would like to ask you one question. For how long does the secondary effects last?
Great question. We'll talk a bit about this as we go over each of the side effects. So as you can imagine, xerostomia, dry mouth, is something that improves over the first 2 years post-treatment, but is never back to normal. Things like mucositis, those resolve much more quickly. Usually most patients, will recover from mucositis within 3 months after therapy. And then some of the late side effects, just in terms of, dysphagia, both can be an acute thing. Most of our patients, luckily, are going to recover from their dysphagia. Patients where long-term dysphagia can be an issue, generally a small minority of patients, again, I will tell you, and it's generally patients with oral cavity cancers that have had massive resections and or reconstructions where there's, you've reconstructed most of their oral tongue, where this can be a significant issue for patients. And then some of the other side effects that I mentioned are really late side effects of therapy that you're going to see 6 months or longer down the line. So things like lymphedema, something that you're going to see late, cervical dystonia, again, something that you're going to see in that 6 month to a year setting in patients. And these side effects, unfortunately, can be lifelong. They don't go away. They need chronic management.
Okay, thank you, Parag. Then I will start the poll now. So, para todos, I will give like 30 seconds to give some time for people to answer. Okay. Okay, Parag.
Very helpful to see, as I would have expected. Most of you have access to a nutritionist, most of you have access to a dentist, but the other services are harder to access. And I think that if I were to take this poll here with US physicians, this is exactly the distribution I would expect. About a quarter of patients really, even in the US, see a speech language pathologist routinely, which reflects, I think, the experience in Latin America. Same with occupational therapists. So managing lymphedema is challenging. And then oftentimes we as physicians are called to manage lymphedema in patients, as you can see. And then about half of you have access to a physical therapist. So that's good to hear. And this will hopefully let us frame some of the things that I talk about soon. So let's start with oral cavity. I want to talk about just some of the things that I think we all expect and see in our patients. Mucositis, pharyngitis, odynophagia, dysphagia, really dysgeusia, altered taste is something that we see a lot of. And then, I know we talk a lot about dry mouth xerostomia, but one of the things that oftentimes, particularly when you're radiating patients within, the base of tongue region, is that patients actually, paradoxically, during the course of radiation, actually get excessive secretions. This is probably one of the very common things that I hear about. We have a large oropharynx population here in terms of head and neck cancer patients in the US, and this is the biggest side effect that I hear about oftentimes that is actually very challenging to manage, is managing secretions, where patients will say, I can't lay down flat at night because I wake up choking in my own secretions. So something that we certainly see during the course of treatment. And as you can imagine, these side effects have consequences. Not eating, not drinking can lead to just loss of appetite, fatigue, weight loss. Obviously, pain being a big part of this mucositis and pharyngitis that you're causing. And then certainly leading into things like weight loss and aspiration. When do we see mucositis? Again, I think that you all know this very, very well. Generally, you can start seeing mucositis and stomatitis quite early. If you're treating patients with radiation alone, commonly in my practice, I start seeing this in the beginning of the 3rd week of treatment. If you're doing chemoradiation, I think one of the things I want to impress upon, all the side effects of radiation are accentuated by chemotherapy. So we routinely use chemotherapy as a radiosensitizer to improve our therapeutic efficacy. But with that comes, that you're also, magnifying all of the side effects that you expect with radiation. So I think, the decision to add chemotherapy is something that we make very, very carefully. And oftentimes, I will say in my clinic, adding chemotherapy or treatment is like 1 + 1 = 3.5, both in terms of efficacy, but really also in terms of side effects I'm going to cause you. So as I'm anticipating side effects for patients, this certainly comes into play for me. Is that decision to add chemotherapy and really the impact on various chemotherapy drugs have different impacts on mucositis. I think we all recognize that. Certainly platinum is the drug that we all most commonly use, and certainly it's a potent radiosensitizer and really contributes to mucositis. I will tell you that, 15, 20 years ago, 5-FU was something that we routinely added, particularly in nasopharynx patients and even in other patients for induction. 5-FU is a potent radiosensitizer and a potent causative agent for just mucositis in patients. So something that we actually really try to stay away from in most head and neck cancer patients today. But mucositis is not just related to where you're giving radiation and the decision to add chemotherapy. There are other things that really come into play for mucositis. And I just wanted to highlight that really it's the patient and the underlying risk factors that the patient has. So, underlying nutritional status, poor dental health, really, and then really concomitant alcohol and tobacco use. And so this is something, particularly, in San Diego, we take care of a lot of veterans, people that have served here in the military. And this is probably the one group of people, even still in California, have much higher smoking rates than our normal California population. And so one of the things when I see patients in consults, I'll always say, if you're an active smoker, I have really 2 reasons why you should not smoke during the course of your radiation or really minimize it. One, I think that the side effects, both acute, especially acute side effects, are really accentuated by active smoking. 2, there's a decrease in therapeutic efficacy. I think there's enough data now to show that active smoking during the course of radiation actually, just leads to worse outcomes in terms of disease control. Other things that can kind of come into play, really immunosuppression. So patients who have underlying, hematologic, dyscrasias or other conditions can really be impacted by this. And then certainly kidney function is another thing that can really play a role in kind of just mucositis for patients. Again, these things that we talked about, concurrent chemotherapy, 5-FU being worse than platinum. Other things that really directly that impact from radiation is radiation dose. I think, there's a lot of exciting work being done worldwide, particularly in HPV-mediated head and neck cancers, to decrease the dose of radiation to gross disease, to decrease the dose of radiation to elective lymph nodes, to change radiation fields. And I think that all of these things are really going to impact our patients in terms of decreasing both short and long-term side effects for patients. Other things to think about, fractionation schedule. So, as you can imagine, 15, 20 years ago, hyperfractionation was the rage, even in the curative upfront setting. But now we realize that, while I am a big fan of hyperfractionation in re-radiation, in upfront de novo radiation, really most patients, especially if you're giving chemotherapy, really you can treat them at standard fractionation. And then treatment volume, something we talked about. The more you irradiate in the head and neck, the more side effects you're going to see. So the decisions to treat every nodal level, you have to do that very carefully because, as you treat comprehensive neck bilaterally, you're going to add side effects in these patients. And then locations. I mean, I will just say, I think we all recognize oral cavity is just hard to treat. You just cause a lot of side effects in oral cavity patients because of you can't spare all the structures that you would ordinarily spare in patients with cancers and other disease sites. This is just some pictures for reference, really more for residents, showing you, how we grade mucositis. I will say that, grade 2, grade 3 mucositis is something that you're routinely, I think we're all seeing in our practice. Grade 4, grade 5, thankfully are very, very rare, but just grade, again, most of our patients are going to get mucositis. Really, grade 2, again, very, very common. And some patients are going to see grade 3 mucositis. So now let's talk about prevention. What things can you do to prevent mucositis? Really, the most important thing that you can do is spare the oral cavity. So in patients where you're treating, oropharynx or larynx or, just tumors that don't involve the oral cavity, it's really important to contour that anterior half to 2/3 of the oral cavity and floor of mouth and try to spare that as much as possible. What dose do we try to spare that to? The answer really is as low as you can reasonably achieve it, a LARA. But I think dosimetrically, if you can keep that oral cavity dose to 30 to 40 gray, you're going to decrease that severity of mucositis in patients. I talked a bit about protons last week, and I will say that while I think the benefit of protons in head and neck cancer is present, it's limited. I don't think it's not like Hodgkin lymphoma where you really get a much larger benefit in terms of late side effects. But I think the one place protons are helpful for most head and neck cancer patients is that you can really spare that anterior oral cavity, where that anterior oral cavity dose oftentimes is less than 5 gray. So that's the one organ that it very meaningfully spares. Other things that you can do, so we talked a bit about last week that dental fillings, especially silver amalgam, is the bane of our existence. Metal crowns that patients have can cause a lot of backscatter. So if you have somebody who has a lot of dental fillings or crowns, you can work with the dentist to build what look like mouth guards. Oftentimes dentists make these routinely for patients who have an overbite to help them sleep more comfortably at night. But you can use this, during radiation, where they can make a mouth guard that is essentially made of this plastic type material, which can really reduce the backscatter and prevent that mucositis, around, periodontal mucositis, and around gingival mucositis in patients. So something to consider in patients, particularly if you're going to be irradiating like a tonsil patient or an oral cavity patient. I think that those mouth guards can be very, very helpful. Other things that I think have really been shown to help mucositis and the severity of mucositis is a drug called gabapentin. So gabapentin is a neuropathic pain modulating agent and something that now I routinely use in practice. So for most patients, especially getting chemoradiation, I will start them on upfront gabapentin starting at week 1 of treatment and then titrate that to what is reasonably tolerated by patients. And I think this has now been shown in multiple studies to really decrease the volume of grade 2 or higher mucositis and just the severity of mucositis in general. And it's been shown to decrease needs for opioids and then decrease need for G-tubes in patients. So something that you can do. Glutamine is another agent that has been used in patients to decrease mucositis. We talked about, again, just avoiding smoking, avoiding alcohol, avoiding spicy foods during treatment. Other things, I think this is a step that we routinely talk about with our patients, just doing gargles with salt, baking soda, and water. The cheapest thing that we can do for our patients, and really to me, one of the most effective, is these oral rinses for patients that you can do. Certainly good dental hygiene becomes really important for our patients. So continuing good dental hygiene is something that we really recommend for patients. I just attach some, just handouts that you can give your patients. There are lots and lots of handouts available on the internet in really helping patients manage side effects from radiation. I just added some from this Multinational Association for Supportive Care in Cancer. Again, this is just the recipe for the salt, baking soda, and water. And again, just kind of showing you how to use this. This is something that I, again, will tell patients to start week 1. It's just doing good oral rinsing during the course of therapy. And then other things that people have used that I think I really like are things like doxepin rinses. So doxepin, as you know, is really a psychiatric medication that can be used on much lower doses. You can actually have your pharmacies compound a doxepin rinse. I now routinely use this. It's a complement to the salt, baking soda, and water. I'll have patients do that. Other agents that have really helped, so curcumin or turmeric, in spice often used in our kitchens. You can make a rinse out of the spice. Turmeric is a very good topical anti-inflammatory agent, and so something that patients will get some good relief from. And then obviously, once patients have mucositis, we use things like magic mouthwash, a concoction of just oral lidocaine or xylocaine with Benadryl and Maalox for these patients. So again, something that we routinely use a lot of. And then obviously opioids. I mean, I think that it is very hard to get a patient undergoing 7 weeks or 6 weeks of radiation or chemoradiation without some opioids, something that we prescribe a lot of. And then I'm going to talk a bit about this. I don't know how many of you have access to dentists who use low light laser therapy for a whole host of non-cancerous conditions, but this low level laser therapy is something that is now really coming into play in the US as an adjunct to decrease the severity of mucositis in patients. For doxepin, this was a recent trial, basically just showing, this was a randomized trial where patients got doxepin, with placebo, and it did, really show that, doxepin did decrease mucositis pain. And again, this is a short-term relief. It's mucositis pain reduction in 4 hours, and you can see that, magic mouthwash is very effective. Doxepin is effective. They're both more effective over placebo. What I like about doxepin is that it's really, it's an adjunct to that magic mouthwash. You can use them both in patients and really help them to decrease that mucositis. This is that low-level laser therapy I was talking about. So this is also called photobiomodulation therapy. It's basically use of this narrow band, laser, essentially. You can see, 630 to 830 nanometers. There are now multiple trials that have looked at the role of laser in patients. And while I will say that generally when you look at individual trials, the results are not overwhelming, but I think that there is a impact on decreasing the risk of severe mucositis in patients. This is a meta-analysis essentially showing that about a 62% reduction in severe mucositis in patients. There was probably the most robust trial, was still underpowered, was a French trial looking at basically time to incidence to grade 3 mucositis. So the trial was underwhelming as you looked at, there was really no difference by laser. But really, I will say that it's the grade 3 mucositis, something that definitely it does seem to improve in patients. So something that I do consider. This is that meta-analysis that I was talking about. And so you can see majority of the benefit, this is in severe mucositis, majority of the benefit is in severe mucositis, not as much of a difference in decreasing the risk of mild mucositis. But once you get to kind of grade 3 mucositis, there appears to be a benefit. This treatment is very interesting. If your dentists offer this, they start this again right at the onset of radiation. It's done 3 to 5 times a week. They go into the dentist, they apply this low-level blue light laser within the oral cavity. The treatment takes about 5 to 8 minutes. And something that I will say that I do like, particularly in my oral cavity patients. Now, the caveat being no medical insurance, at least in the US, covers this. And this is a big out-of-pocket expense for a lot of our patients. So something that you have to be mindful for in patients before you offer this. But if they can afford it, I do think that this is a reasonable thing that you should consider. So as we kind of wrap up mucositis, I'm just curious to see, these are some of the common things that people use, and I'm just curious which of these do you offer currently in your practice? So we'll take a poll.
Thank you. Okay, we'll give 30 more seconds. There are some questions. Well, I think one of them is, what is the right time to prescribe the laser therapy, Parag? What do you think?
I think that if you have access to a dentist who does this laser therapy, I think starting them up front is reasonable. So all the data essentially suggests that it decreases that severe grade 3 mucositis in patients. And I will say that in my practice, I was a skeptic, I'll be very honest. I started doing this about 4 years ago, and the data really is not very, robust, because all of these trials are generally underpowered. But in my practice, what I find is that the low-level laser does 2 things. One, it delays the presentation of mucositis, particularly, grade 2, grade 3 mucositis. So it's not just reducing the volume where you see mucositis, but side effects that I generally would expect, week 3, week 4, I now see them week 7. So I do think that it really does help patients. So the earlier you start, the better. I'm looking at the poll results. And so again, most of us use salt, baking soda, and water, and I still think it is one of the most effective treatments for patients. But I really hope that after this course that you will start thinking of using doxepin, because doxepin is very cheap. It's not expensive. These are generic drugs. And also gabapentin. We've put in the recipe of how to prescribe gabapentin. Really, these are 2 other agents that I think really help patients in reducing mucositis. So things that you can consider.
And Parag, can you use all of these in combination?
Yes, I think that that's the good thing, especially doxepin rinses and salt baking soda water rinses. I usually tell patients to alternate them. And so you can certainly use those. And then gabapentins, especially if you're, really doing a significant volume of kind of mucosal irradiation. So again, I keep harping on oral cavity patients, but those are the patients we all know get a lot of side effects. So for those, really starting with gabapentin up front for those patients is helpful. For other sites, if you want to start once the side effect starts, it's reasonable, but you can certainly start all of these in tandem up front. Okay. Taste, again, as we all know that, our taste buds, really the majority of our taste buds are in the circumvallate papillae, right at the junction of the oral tongue and base of tongue. But we do have taste buds scattered all throughout the oral and pharyngeal mucosa. And really, as I'm sure we all experience, week 2, week 3 of treatment, one of the first things patients tell you when you see them is saying, I have no taste, nothing tastes good. This is a common side effect in patients. As you can see, it's reported in virtually every study. You can see the majority of patients are going to say that there's an alteration of taste. And then this is kind of how the trajectory of those taste changes are. I think we all know, as I mentioned, generally week 2 is where our patients start reporting this to me. It really peaks at the end of treatment. And you can see that taste recovery is slow. It's very much like xerostomia. It slowly but surely gets better. But most patients will have, close to background taste, by 2 years. But certainly takes a while. The more the volume of how much oral tongue and base of tongue you're radiating is directly proportional, I think, to taste changes. So again, oropharynx, oral cavity patients probably suffer the most taste changes compared to, say, a paranasal sinus or a nasopharynx patient. Again, this is one of those things which is hard to manage. Again, chemotherapy adds to the sense of dysgeusia. There are people that use zinc sulfate supplements to help with taste recovery. The key thing to me just really is just adequate nutritional support, and just being cognizant as the oral, just biology of just kind of the oral microbiome is changing, just to be mindful of, making sure that if your patient is developing oral candidiasis or thrush, that you're actively managing that in patients, something that you will see in patients. But really taste is, we don't realize how much taste impacts us. Taste is directly related to your nutritional intake. And so, as patients lose taste, it becomes really, really important to make sure that patients are getting enough nutritional content in their foods. This is just showing you kind of, next we're going to talk, I think, about parotids, and kind of just showing you these are our typical volumes of radiation. I put in some 2D, 3D kind of, DRRs of what we used to irradiate, and you could see that the salivary glands were completely, especially your parotid glands, were completely in the radiation field. Really, the advent of kind of modern radiotherapy has really allowed us to spare salivary glands in patients, particularly the parotid glands. So as we think of xerostomia starts early. You will see that patients will start reporting this at really, within week 1 of radiation, with doses as low as 10 gray. And really what you'll hear patients kind of report both is that they have dry mouth both at rest and really a very dry mouth as they're chewing food. So eating certain foods like toast becomes really, really difficult during the course of radiation because there's just not a lot of saliva produced with mastication for patients. This is, again, just kind of more information on just kind of what saliva does. As I talked about, besides a masticatory and gustatory component, really, saliva is a potent antibacterial and it's an antiseptic. So really, it does change kind of the oral flora for patients. And you can kind of see one of the things that patients will report, and I think something that my residents often get confused is, as you get dry mouth, you will have essentially, your sputum that will dry up and kind of adheres to the tongue. And this is what that, looks like. And so sometimes patients will make up with this whitish coat on their tongue in the morning. And oftentimes, some of my residents who have not done a lot of head and neck cancer will say, oh my gosh, the patient has thrush. And what it really is just dried sputum on their tongue. But certainly, xerostomia can lead to oral candidiasis, particularly, I think, in patients who have dentures. And so something to be mindful of, that's something that you will see in these patients. And this is just showing you xerostomia comparing, this is the landmark PARSPORT trial that looked at patients getting 3D conformal radiotherapy versus IMRT. And this is just showing you the rates of grade 2 xerostomia post-treatment. So this is looking at patients after completing radiotherapy. And you can see that with conventional radiation, that xerostomia is unremitting. It never goes away. Patients have dry mouth for the rest of their lives. Versus with, a good VMAT plan where you're at least sparing one parotid gland, xerostomia does improve over time. And you can see that still about a quarter of people still have grade 2 xerostomia, but vast majority of patients will report improvement in that grade 2 xerostomia. And this is, again, this is looking at parotid function. So this is stimulatory saliva when you're eating or chewing. It is not resting saliva. This is, again, showing you that same data, basically showing you, again, this is now showing you from onset of treatment. So you can see, xerostomia kind of starts week 2. And then you can see with 3D conformal radiotherapy, it never really gets better. With IMRT, especially if you are able to spare one parotid gland, it will improve in the vast majority of patients. This is a very interesting study out of British Columbia. We're going to talk about all these organs at risk in our subsequent talks and what doses to keep them. Most of us try to keep that mean spared parotid dose to, less than 26 gray. But really, you really want to spare that one parotid as much as possible. So this is the mean dose to the spared parotid gland. And this is just showing you kind of relative, salivary flow in these patients, over baseline as they recover salivary function. So the black dots are at 3 months, the clear dots are at 12 months post-treatment. So you can see the more you spare that contralateral salivary gland, the better the recovery of that salivary function. And then again, you see that once you get to radiation doses of kind of 30 gray or beyond, you really don't spare that salivary function. So just be mindful of that salivary gland sparing in patients. The more you can spare, the better patients will do. Again, this is just that data kind of showing you, just the role of kind of parotid sparing and salivary gland function for these patients. Amifostine was a drug. I should just take this out. This was big 20 years ago when I was in training. It was an FDA-approved drug to decrease rates of chronic and acute xerostomia. Again, I will say that the impact of amifostine, honestly, for those of us that have used it, will say it was just modest at best. This drug had a lot of side effects. It is no longer used in the US at all for xerostomia. But this is the only drug so far that was kind of FDA approved to be used during radiation. This is just showing you some parotid sparing. So this is a base of tongue patient of mine with locally advanced base of tongue cancer. You can see bilateral neck node. This is an HPV-mediated oropharynx patient. And you can see a nice IMRT plan will really help you spare parotids, hopefully at least, on the contralateral side, but even on the ipsilateral side where you can spare the superficial lobe of the parotid gland. And you can see in this particular patient, my mean parotid doses were on the order of 20 gray for both glands. But I think what IMRT doesn't do for you, at least unless you are intentional about it, is that you don't spare submandibular glands. So this is that same patient. Again, you're showing you this base of tongue tumor on the left side, and you can see these radiation volumes, and you can see that the mean dose to that submandibular gland are almost on the order of your therapeutic doses. So 56 gray on the contralateral neck, which is my dose to the contralateral neck, and then close to 70 gray on the ipsilateral neck, just because of the location of where this is. So I mentioned the parotid gland is really more about stimulated saliva. So when you're talking, chewing, eating, your submandibular gland produces majority of your resting saliva, so the sense of dry mouth that you have at rest. So if you don't spare it, no matter how wonderful a job you do of sparing the parotid gland, your patients will still say, I have a dry mouth throughout the day. And that's not uncommon. So really, this is where, if you can spare the submandibular gland, this is where you're going to improve really that sense of dry mouth at rest. And how do you do this? So this can be done surgically. So this is a surgical transposition of that submandibular gland. And you can see basically this is an outpatient surgery where the head and neck surgeon transposes that gland to the submental space. This is one of my patients. And you can see now I can generate a really nice IMRT plan. So this is that same patient. We planned this patient before the transfer and then after the transfer. And you can see that now we can spare this gland much, much better. So you can actually prioritize sparing of that contralateral submandibular gland now with mean dose of 10 gray. We're just finishing a feasibility study here at UCSD, and really this is probably one of the best things that we've done in patients is to spare that submandibular gland and improve long-term xerostomia. So this is again just showing you some kind of pictures of that submandibular gland transfer in patients. There were studies done particularly in the 3D era, but I do think that this actually is of value even in the IMRT era, is to really do submandibular gland sparing in these patients. This is a phase 2 trial now done over a decade or so ago, just showing you that if you look at late xerostomia in patients where you're not sparing the submandibular gland, and I kind of talked about even in the ParSport trial, a quarter of patients reported grade 2 xerostomia 2 years out. Most of the other studies show about a third of patients reporting grade 2 xerostomia 2 years out. But if you are able to spare one submandibular gland, that drops down significantly to, as you can see, to less than 10% incidence of grade 2 xerostomia. So I do think that if you have a head and neck surgeon who can partner with you, sparing a submandibular gland in addition to sparing a parotid gland can be very, very meaningful. I routinely will do this in patients that have unilateral neck disease, but need bilateral neck radiation. So classically, our oropharynx patients, where, I'm going to treat the bilateral neck and I need, I can really help those patients. Unfortunately, in oral cavity, this doesn't work, again, because, you're generally radiating bilateral level 1 lymph nodes in oral cavity patients. So really not a meaningful way of sparing the submandibular gland in these patients. Lots of things that we use for dry mouth long-term, certainly things like biotine rinses, biotine gums, chewing gum that patients will use. I think, like lemon drops, vitamin C tablets, these are all gustatory stimuli. Chewing gum is a tactile stimuli. One of the agents available for long-term management of xerostomia is a drug called pilocarpine. This is an anticholinergic agent that you can use in patients that really have significant xerostomia, chronically post-treatment. And the efficacy of this is about 50%, I would say. And, half the patients tolerate this, the other half just have a lot of side effects and can't tolerate this. But this is something, especially in my survivorship clinics, I will use on occasion in patients that have really, really bad chronic dry mouth. Other things that you can think about, acupuncture. There are some acupuncture studies that both done in patients while they're undergoing head and neck treatment and after that have shown to decrease xerostomia. There is an NIH study looking at viral vector, essentially gene transfer therapy into the parotid gland to increase salivary flow. So there are lots of really novel approaches. I'm sure in prostate cancer, people are using space OARs to spare the rectum. There's interest in kind of using a similar bioproduct to displace the salivary glands. It's a little trickier, as you can imagine, to put a bioinert substance in your cheeks, particularly anywhere near your parotid gland because of the facial nerve, but there is interest in that, and I know people are starting to look at that. So a lot of work being done in this space. So we'll go to a third poll at this point. So if we can do this poll.
Thank you, Parag. Okay, Parag, I think we have these results.
Yeah, so now I'm going to tell you my answer. I do all of these depending on the patient. So let's go one by one. Obviously, I think vast majority of you try to spare one parotid gland, and I think that that's great. I think that's really important. About, a fifth of you are trying to spare a parotid and a submandibular gland, and I think that's great. I wanted to this is a prelude to some of the talks that are coming. We're going to talk about level 1 nodes and when to treat level 1 nodes. And what I will tell you, just as important as to when to treat level 1 nodes is when to not treat level 1 nodes. Because if you can spare level 1 nodes, you will spare the submandibular gland better. So I think that becomes really, really important. So, if you have access to a surgeon who wants to do this surgical procedure, great. The vast majority of people, in the world don't have access to that. So that's why I think that even as you're designing and contouring your patients, if there are patients where you recognize that the risk of a isolated level 1 nodal failure is low, and you can eliminate that region from your radiation contours, your treatment planning contours, then I think that you can spare that submandibular gland. I think number C, it's just we're kind of getting to the concept of adaptive radiotherapy, and I think that this is really important. I think one of the things that I want to impress upon is you'll evaluate plans in this course, and we'll talk about treatment planning. Evaluating the plan prior to the onset of treatment is one static point in time. The reality is that that one plan that you've signed off before the onset of treatment and what the patient actually gets during the 7 weeks is vastly different, especially as the head and neck anatomy changes and our patients lose weight. In fact, people have looked at this, people have evaluated, have done cone beam CTs for all 35 fractions of a head and neck patient, and then looked at dose planned versus dose delivered. And the reality is, as patients' weights, patients experience weight loss, which almost every head and neck patient does, you're actually sparing less of the parotid gland, because what happens is more of the parotid gland falls within the radiation volume, especially the deep lobe of the parotid gland. And so something to be mindful of is that if you have the opportunity to build in replanning for your patients, it's something that you should really consider. And especially with these newer newer software that we have in our treatment planning software, where the replans don't take as much time, where you're able to take your initial contours and deform them versus recontouring a head and neck case from start, is something that really can be very, very important in sparing organs at risk in your patients. I don't know how many of you have the newer machines that, these that have adaptive components, and if you do, I know that this is an area of interest for a lot of people if you can just do adaptive replanning every day. I will tell you, head neck is very different, say, from a pelvic malignancy, where there's day-to-day changes in rectal filling and bladder filling. So I probably, my sense for head neck replanning is that, you don't need to do it every day, but if you're doing it even every couple of weeks, especially in patients where either the tumors are shrinking rapidly or there's a lot of weight loss, there's value to that. And then I put this intentionally, I don't pay attention to salivary gland doses. Now, I will tell you, there are head and neck cancer patients where you just have to treat the disease, and it's not uncommon even here in San Diego to see patients, what I call with T10, N10 head and neck cancers, where literally every nodal basin is involved, their entire mouth is one big cancer. And in those patients, really you can't spare anything. And so I wanted to just reflect the reality that many of us face sometimes, that there is a subset of patients where treating the disease means that you're doing very little sparing, and really you're focusing on symptom management for those patients. Excessive salivation. So I talked about this. This is one of those kind of side effects that honestly, the more I treat, I realize is a big issue, is hypersecretion that patients can get during treatment. Typically, we'll use anti-cough medications, so antitussives, so guaifenesin. Sometimes we'll add dextromethorphan in these patients to help with secretions. But other things that sometimes we'll use, 2 agents that I think find very, very helpful to decrease that excessive secretions during treatment is anticholinergic agents. So you can use either a scopolamine patch in patients to decrease that, hypersecretion, and sometimes using glycopyrrolate rinses in patients to help with secretions. Other things that you can use, anti-anxiety medications. This is, I should have put a poll asking this questions. How many of you prescribe anti-anxiety medications for head and neck cancer patients? And I will say in my practice, about a quarter of patients require anti-anxiety medications for a whole host of reasons. One is for secretions, other is for claustrophobia with the mask. I think we underestimate how many patients really have significant claustrophobia. So something that you can use. And then ultimately, really, this is where that rehab comes in, is, especially in oral cavity patients, we routinely use portable suction machines that patients have at home to be able to suction their secretions, while they're undergoing treatment and while they're recovering from treatment. So something that comes into play. Thrush, again, something that you can see in patients as the microenvironment of the oral cavity changes, and so something that we have to be hypervigilant about. And as I mentioned, this is especially a big issue in oral cavity patients and/or patients that have dental prosthetics. So using something like nystatin or fluconazole is something that becomes, something that I know routinely use in patients to help manage thrush in patients. Rarely in some patients, you can get reactivation of HSV. And this is really something that I see in combined modality therapy patients getting chemotherapy and radiation, they'll get this HSV reactivation. And this often is timed right as their counts are going down. So as they're becoming neutropenic, you'll see this in patients. And so if you see a concomitant HSV infection, starting them on antiviral therapy, whether that's acyclovir or valcyclovir, again, becomes important in really managing HSV stomatitis that you can see in patients. Now moving to some of the more late side effects of radiation, trismus. So this, as you know, is fibrosis of the muscles of mastication, but especially with, just right at the TMJ. So you can see this mandibular condyle sclerosis, mandibular joint capsular thickening. And this is something that, again, is something that we see in really two subsets of patients: locally advanced tonsil cancer patients, where there's disease going into the pterygoid musculature, and there's no way for you to be able to spare the pterygoid musculature and the TMJ. And then oral cavity patients, where you can really get trismus in these patients. This is one of those things, I think is very, very challenging to treat. There's no fix for trismus. You can manage it, you cannot fix it. So things that, really, this is where I think the physical therapy team comes in really, really handy. So especially for oral cavity patients, we start, physical therapy right after surgery in these patients, especially if they've developed trismus after surgery or have trismus due to the cancer. And you can do these mandibular stretching exercises. So you can see here a picture of somebody putting these tongue blades to kind of help stretch them. There are machines that can do this, so you don't necessarily need to use tongue blades to help with kind of oral cavity stretching. But this is something that patients have to really be vigilant and do this very, very regularly, because otherwise trismus is something that just worsens if you're not actively managing it. Again, there are some of these dose constraints that can kind of to prevent trismus. I think one of the other things when patients have severe trismus that people have used and that I will also sometimes send is to an interventional pain management person using Botox injections into the pterygoid musculature, something that they will do. And these are temporary fixes, though. The Botox lasts 3 to 4 months, and then they require repeat injections. But trismus can be both functionally deforming, as you can imagine, and it can be very painful. Patients will say that they have severe pain from trismus. So this is one of those unfortunate side effects that we really, even today, don't do very well in. Next, dysphagia. Again, we're very commonly used to dealing with dysphagia, and really it's just because, majority of the cancers that we treat are in the pharyngeal axis. And, we're irradiating significant portions of the pharyngeal axis. So this is a common side effect from, treating nasopharynx to hypopharynx patients. All our patients are going to get dysphagia because of irradiation of that pharyngeal axis. And really, to me, the onset of dysphagia is really, again, similar to onset of mucositis. Again, starts usually about week 2, week 3 in patients. Luckily, in vast majority of patients, this improves over time. And so usually when you're seeing patients in 3-month follow-up, a majority of patients that their dysphagia has significantly gotten better. But there is a subset of patients where that dysphagia really can become chronic. And again, that is dependent on location of the tumor, the dose to all the pharyngeal structures, and sometimes just end organ dysfunction that can be caused by cranial nerve injury in these patients. So what are some of the organs to spare to prevent dysphagia? Really, the two kind of main organs that have been shown is really the constrictor muscles. So, pharyngeal constrictor muscles, and then the other is looking at supraglottic larynx. So those are the two main structures that have really been shown to decrease the severity of dysphagia. This is just some normal tissue toxicity probability, planning, based on planning doses. And you can see just really, what I want you to take away is that it's really, once the mean dose starts going above 45 gray, you're going to start seeing issues in patients. So this is looking at superior constrictor dose in combination with supraglottic larynx dose. So again, kind of showing you the likelihood of what you will see in patients. So as these doses, both of these doses go beyond 45 gray, increased incidence of really experiencing swallowing dysfunction. This is data from Denmark. And the other thing really in dysphagia, again, it's not just the radiation dose or the radiation volume. Other things that go into play is just the health of the patient. So older patients just have a higher risk of dysphagia at baseline compared to younger patients. Patients with neurologic conditions, particularly Parkinson's disease, really have very high rates of kind of organ injury that doesn't always recover. So just be mindful that there are other factors that go into play beyond radiation dose and radiation volumes, including things like age and underlying health of patients. This is again just the same study, just showing you that in this particular study basically was the superior pharyngeal constrictors and the supraglottic larynx and cricopharyngeus doses that were most predictive of late toxicity in patients. This is Michigan data, again, just showing you this is pharyngeal constrictor dose and likelihood of dysphagia. And again, all I want you to take away is, once you get to radiation doses north of 50 gray, you can see that sigmoidal increase in risk. And this, what I like about this study is it's actually doing fluoroscopic analysis. So it's actually visual documented increased risk of aspirations and kind of those video fluoroscopic scores. You can see they look very, very similar in higher doses for patients. This is, again, also looking at supraglottic larynx dose and risk of aspiration. And again, just showing you, doses north of 45, 50 gray really become an issue in our patients. Late dysphagia is rare. It really is a different mechanism of injury. It's not that it's beyond that acute inflammation. It's the acute inflammation leading to fibrosis, vascular, and neural damage in these patients. And again, it's something that is fortunately not something that is very, very common, but it can certainly something that I see in my practice, particularly in patients with combined modality therapy. This can be an issue in patients, particularly in base of tongue patients where that supraglottic larynx and the inferior constrictor muscles see a lot of dose of radiation. This is, again, just that Danish study looking at patterns of long-term swallowing dysfunction. And you can see that, this is the small group of patients that have either progressive or moderately persistent or severe persistent xerostomia. And this is something that you will see. These are late side effects. So these, again, you're really, noticing in patients, year down, 6 months and beyond in terms of what you notice in patients. Versus the vast majority of patients, it's really this transient or low persistent dysphagia. So it's, things that really get better. Fortunately, this is not in a very high group of patients that you will see. This is basically a heat map showing what predicted the likelihood of that, severe persistent or progressive dysphagia. And you can see basically these are all the structures we're going to talk about as we talk about organs at risk. And you can see it's, constrictor muscles, it's, base of tongue region, it's supraglottic and glottic larynx, and salivary glands. So, dysphagia is not just function of dose to one organ. It's really multifactorial as you're really irradiating the pharyngeal axis in these patients. And really what I want you to take away is that when you look at severe persistent dysphagia, look at the heat map. It's where patients are getting high doses to virtually every organ. That's where those are the patients that are most at risk for these patients. This is something that we'll go over a lot in our future talks. Basically, all the various dose constraints to spare this. As just very recently, the dysphagia associated radiotherapy sparing trial was just published from the UK. Again, showing you that, in addition to parotid sparing, if you can meaningfully spare, particularly the, portion of the constrictor muscles and the supraglottic larynx, that you can improve outcomes in terms of dysphagia for patients. In terms of kind of management, again, really working with speech therapy is the biggest issue. And so this is why, if you have access to speech therapy both during treatment and after treatment, really it's swallowing exercises that you really have to work both during the acute and the recovery phase with these patients to help them swallow correctly. So if you have access to a speech language pathologist, they can really be instrumental. Dysphagia, as we all know, can lead to poor nutrition. And really, this is, in terms of feeding tube use. And I will say that prior to the routine availability of having a speech language pathologist and a nutritionist in our team, 7, 8 years ago, we used to routinely just put prophylactic G tubes in all of our patients that were undergoing chemotherapy and radiation. Now we don't do that because really having these folks on the team make a big difference. And so now, our use of G tubes during chemoradiation is on the order of, about 25% of our patients. So something really that becomes very important. A small minority of patients require G-tube life, beyond a year. And again, these are really especially oral cavity patients that have had trimodality therapy, where this becomes an issue where they require a G-tube for a long time. So we'll do another poll at this point. So I just wanted to know how you all manage dysphagia during treatment. So let's stop into the poll.
Thank you, Parag. And I will ask you a question. Do you use in your routine practical gastrostomy tube as a prophylactic or not?
Yeah, no, that's a great question.
For
So we
oropharyngeal cases, what do you do?
Yeah, great question. So we don't routinely put G tubes. So the people that we will put upfront G tubes in are patients who have severe trismus at diagnosis from their tumors. And then in patients where especially oral cavity patients that are going to get trimodality therapy. So they're getting surgery and chemoradiation. They've had big bulky flaps put in the oral cavity where swallowing is going to be affected. Those are the only patients where we prophylactically put a G tube in because it's so challenging to get them through treatment otherwise. Otherwise, really, we work with our speech language pathologists and nutritionists and just monitor patients. So they get video fluoroscopic evaluation every other week while they're going through treatment. And so we're actually physically monitoring them if they're getting, if they're starting to aspirate. And if that aspiration is not fixable with exercise, then we'll add a G tube at that point in time. So it's about a quarter of patients who get a tube. But if you asked me this question 10 years ago, I would have said 100%. Because the worst thing I can do for a patient, the worst thing I know you don't want for your patients is for them to get such bad dysphagia week 3, week 4 of treatment, where now you have to give a treatment break to get the tube in. Because that's the worst thing we can do for our patients is to stop radiation week 3, week 4 for days or a week. And so to prevent that, we used to put G tubes in all of our patients. And I will say, if you don't have access to good nutritionist or a speech language pathologist, I think still many places in the world use a prophylactic G tube. So I don't think it's the wrong answer depending on the resources you have.
Thank you, Parag. Okay. That's it, Parag. Let's go.
Yeah, so look at that. Very, kind of what I would have expected. So a quarter of you put G tubes in everybody, and I can certainly understand why you do. About a third of you refer patients to a nutritionist or speech language pathologist when the patient is on treatment. And I think that's wonderful that you have access to this. About a third of you put in a G tube when they lose about 10% or more of their baseline weight, which I think a lot of people across the world still kind of use that as a threshold. And then, about a third of you refer patients when they stop swallowing solid food. So again, I think this just reflects the real life kind of what we all do and see in our practice. But again, just reflects that this is a big issue. Dysphagia is a big issue for our patients. And so, as we contour, this is one of the most important side effects that we are mindful of in sparing dysphagia associated risk structures, basically in our patients. Some last couple of things, I think, lymphedema is something that, as we talked about, something that you will see in your patients. And it's multifactorial. So it's, especially patients who have had a neck dissection, especially if they've had a level 1 neck dissection or surgery for an oral cavity tumor, something that I think patients are at highest risk. And then again, just like breast cancer, there's a difference in when you take out 5 nodes for a neck dissection versus when you take out 100 nodes in a neck dissection. The more comprehensive the neck dissection is, the higher the risk of lymphedema that you're going to experience in patients. And then certainly, as I mentioned earlier, if you're treating especially level 1, level 1A and level 1B lymph nodes, submental and submandibular nodes, those patients really get pretty significant lymphedema. So here, having a lymphedema therapist, just like what we use for our breast cancer patients, can be very, very helpful. What you will see is that they will, one, beyond kind of measuring lymphedema, they really help manage it. And the managing here is manual lymphatic massage. That's the most common way to do it. And then there are essentially these pneumatic devices that you can use in patients, to really help with that kind of, pneumatic compression and drainage in patients. So something that, if your patients develop lymphedema, this is what that pneumatic device looks like. You can see something that you can use. These are expensive. So the other thing I will tell you, most insurance companies don't cover this. This is on the order of over $1,000 here in the US. So these are not cheap. So the reality is vast majority of our patients just get manual lymphatic massage drainage, basically. Other rare side effects, again, laryngeal toxicity. Fortunately, in the IMRT era, this is not very, very common. Until recently, as I'm sure, immunotherapy is changing the landscape of every solid tumor, including head and neck cancer. And with concurrent immunotherapy in patients, we're now starting to see kind of just edema of organs, and including laryngeal edema that happens, essentially kind of in the 3 months to 1.5 years post-treatment in patients. So something that you may see in patients is this laryngeal edema. Otherwise, we just see mucositis really in the base of tongue, supraglottic larynx region. That's not uncommon, temporary laryngeal edema, especially when you're treating base of tongue tumors or larynx tumors, where patients get significant edema of the area epiglottic folds and the arytenoids, where their voice quality is impacted, their swallowing can be impacted. And these, luckily for most patients, is going to get better with time. But the late laryngeal edema really, I think, is not, fortunately, a thing of the present. But if you start using immunotherapy, it's something that I want you to be aware of, something that we certainly are seeing in these immunotherapy patients where they get laryngeal edema. We're all used to looking at scopes that look like this post-treatment, where there's a lot of epiglottic edema, and you can see here arytenoid edema, and luckily all these things generally get better. But again, if you can spare larynx to, about 40 gray hair or less, that risk is something that you can really decrease for most patients. This is, again, just showing you some pictures. When patients get to, grade 4 edema, where there's significant obstruction, then you really do have to think of putting a tracheostomy in patients to maintain an airway. So something that you have, the head and neck surgeons are very mindful of. And if you have the opportunity to scope your patients, something that you should be mindful of in patients. Radionecrosis, again, exquisitely rare radionecrosis of the larynx. We don't see very often, but can happen rarely in patients. And, if that happens, radionecrosis of the larynx is very, very hard to treat. People try hyperbaric oxygen to see if it helps. But in worst case scenario, patients need a laryngectomy. So this is not something that is easily manageable. And it's hard. This is a clinical diagnosis. And oftentimes, especially when you see late necrosis around the larynx, one of the things you're often worried about if there's a supraglottic larynx recurrence. And really, imaging is not very helpful here. And even biopsy has to be done very, very carefully, because if you biopsy these patients, if they don't have tumor recurrence and really do have necrosis, the biopsy will worsen this. Again, you can see it's just this chronic inflammation and vascular damage that really causes laryngeal necrosis in patients. And as I mentioned, really, hyperbaric oxygen is classically what we'll use. You can certainly use steroids. I should have mentioned that, antibiotics and steroids are something that we'll use in patients. But ultimately, if you can't improve in these patients, really, they're going to need a laryngectomy and get a permanent tracheostomy. But classically, if you're seeing laryngeal edema, in the 3 to 2 year period post-treatment, really, especially in a, supraglottic larynx patient, you really have to worry about the risk of tumor recurrence, because oftentimes edema is just the first indicator that there is a recurrence of tumor in patients. Next, dental cavities, dental caries. Again, this is something that we see a lot of. Luckily in the IMRT era, this is much better than when it was in 3D conformal therapy. But this is, dental cavities. So, having, access to a dentist, both prior to the onset of treatment and really once patients finish treatment, for maintaining good dental hygiene is really, really important. but you can start seeing, radiation impacting essentially the dentino-enamel junction at pretty low doses, even at radiation doses as low as 30 gray. And then it's really a big issue, at higher doses, at doses over 60 gray. So this is just, we talk about osteoradionecrosis of the maxilla or the mandible, and it's really just based on tumor location in patients. So again, as I mentioned, IMRT era has decreased the risk, but it's not zero. Risk factors for this tumor location. And then starting radiation around a dental extraction. So there's actually a couple of studies that basically show that once, if you do dental extractions prior to radiation, really need to wait about 2 weeks before starting radiation, because otherwise poor healing post-dental extraction is a significant risk factor for future osteoradionecrosis. Medications are big. I think that we underestimate the medications our patients are on. Sometimes that can really impact this. Bisphosphonates, I know, in breast cancer, there's literature of kind of ORN of the, mandible after bisphosphonate therapy. But if your patients are on bisphosphonates during radiation, it's again something that you have to be mindful of. Other medications like chronic steroid use, VEGF inhibitors, and other drugs you can see here that we use in cancer care can really impact that risk of osteoradionecrosis. And then other things I think that we don't give enough recognition to. Diabetes is a risk factor for ORN, so which is not uncommon for a lot of our patients to have things like peripheral vascular disease or diabetes, and these do definitely increase the risk of osteoradionecrosis. ORN can, as present with just exposed bone. It can lead to pathologic fractures. It's certainly a cause of significant morbidity in patients. Lots of different studies just showing you incidence of osteoradionecrosis, in the IMRT era. And you can see, fortunately, it's generally in single digits in terms of that risk, but it is something that is there. Lots of constraints for mandibular sparing. You can see here, just really watching the volume, getting really anything beyond 50 gray is something that you really have to be mindful of. Good dental prophylaxis is really important. And then fluoride supplementation. So I think that, once patients finish treatment, it's really, really important to make sure that they are getting fluoride supplementation, either with fluoride trays, where again, it's those mouth guards I talked to you about, where you can put the fluoride gel for about 5 minutes at night to essentially, provide extra concentration of fluoride to the teeth, or even just a prescription strength fluoride toothpaste, which oftentimes, you can prescribe for your patients. This is something that I do routinely. Again, as I mentioned, only about half of our patients, even here in San Diego, have access to routine dental care. So unfortunately, this falls on the radiation oncologist to maintain good dental health for these patients. One of the common questions I get is, hey, are dental implants safe in post-radiation? And historically, I think we used to say no, right? So if somebody needed a dental extraction, and after extractions, you would say, gosh, you need to just get dentures. Now, I will say that dentists are offering dental implants. They wait, usually on the order of a couple of years before they do these dental implants. We use hyperbaric oxygen routinely for dental extractions and dental implants. So if somebody either needs a dental extraction or an implant, if you have access to hyperbaric oxygen, having patients undergo hyperbaric oxygen both before the extraction and after the implant is something that, most dentists will put patients through to decrease this risk for patients. And the management for ORN, really, as I said, antibiotics, supportive care. You can add hyperbaric oxygen, and then really it's surgical. Really, the management is surgical. This is looking at a single old trial, looking at HBO versus antibiotics prior to extraction. And HBO did reduce subsequent risk of ORN significantly in these patients. And so something to consider in patients. Again, as I mentioned, pain management, antibiotics as first-line therapy, surgery really is second-line therapy, and then really adding HBO. People have used this kind of combination of kind of pentoxifylline and vitamin E with antibiotics and steroids in management of ORN. The problem with these kind of medication-based regimens that they take a really long time for any impact. So when patients have acute ORN, it's really hard to put them through this and wait to see any relief in patients, because it really takes on the order of 3 to 6 months before you notice anything. So not something that I routinely do in patients. Last couple of things, pain, we talked about this already, just chronic pain, neuropathy, talked about the use of gabapentin in patients during treatment. And so something that we routinely do. I think this is, again, something that we routinely put patients on gabapentin now during treatment, and then usually wean them off gabapentin within a couple of months after treatment. So something just to be mindful of in patients. And then lastly, I think one of the things that I don't know that I do very well is just life impact of head and neck cancer. It's really things like depression, anxiety, distress in patients, both during treatment and as they recover from treatment. And so, if you have access to social workers and therapists, this is really something that we underappreciate, underdiagnose, and undertreat. And so something really that, I think that this is such a big part of every patient's cancer journey, and head and neck cancer patients are no exceptions to this. And so if really, being able to do depression screening, distress screening in patients is really, really important. The people have used antidepressants in head and neck cancer patients. There's actually a trial that about 10-year-old using citalopram in patients. And so something, in patients where if your depression screening prior to the onset of treatment is positive, I think referring them to a therapist and a psychiatrist to put them on antidepressants, or even a primary care doctor standing an antidepressant, can be very meaningful for these patients. And then,
Parag?
yeah.
Hi. We have a lot of questions.
Oh, great. Well, maybe
in the
stop and
chat.
take some questions.
Yeah, maybe that would be good. I'm not sure how many more slides there are, but they're
We can
written so
save this
beautifully.
for the last talk. That's fine. We'll stop here.
Okay. Okay, great.
Thank you, Parag.
This has been so amazing. Like, man, the density and of the knowledge, I feel like I want to go back and read every slide again. This is so good.
Parag, I think we can do two questions, and then we will close the session if it sounds okay. One of the question is, at what time after radiotherapy do you think it's safe to proceed with dental procedures?
Yeah, great question. Very, very practical. So I definitely recommend waiting at least 6 months, ideally a year. So it depends on what the dental procedure is. So if it's like a deep cleaning, I think that that's fine anytime. A root canal, I usually wait about 6 months. The one that I get most nervous about really is extraction. So one of the things that now we routinely do is, I don't know how many of your dentists ask for the radiation plan, but they now in many dental schools, they actually teach them how to look at radiation treatment plans and radiation dose. And so oftentimes we'll send them these thin cuts both through the maxilla and mandible, showing them the radiation dose and they can then model what the tooth saw in terms of radiation dose, which is great. Typically for extractions, I like to wait a year. And if that tooth has seen radiation doses, north of 50 gray, which is not uncommon, right? Especially in a tonsil patient or an oral cavity patient, depending on where that tooth is, it may have seen that dose of radiation. Those patients really doing dental extractions can be very, very important for those patients. I'm sorry, doing hyperbaric oxygen prior to dental extractions can be very important for those patients. So dental extractions, waiting a year, and then if you have access to hyperbaric oxygen, using hyperbaric oxygen.
Any experience with hyperbaric oxygen?
Yes. And so, yes, especially for extractions, I routinely do. So the one caveat I will say, you have to make sure that your patient is cancer-free. So, because one of the things, as you all know, hyperbaric oxygen, increased oxygenation is great for wound healing, but it is also great for tumor proliferation. And so you have to be mindful of that. But yes, I routinely use HBO now for extractions, especially patients, 2, 3, 5 years out. It's something that we routinely use. And as I mentioned, so usually they do on the order of 20 to 25 dives before the extraction, and then another 10 to 20 dives after the extraction.
Wow. And you told, so many years after radiotherapy, you recommend the hyperbaric oxygen before
I
extraction?
do.
I think that's a great tip.
It is because I think the vascular injury, the vascular changes are lifelong. So those
Okay.
don't get better, right? So even though clinically and you're doing an oral exam, visibly you're not seeing any damage, the vascular structures are the intima of the vasculature is essentially completely impacted. And so the wound healing is just not going to be very good, especially in later, and something that you just need to worry about.
But thank you so much for this amazing lecture.